you.
you.
Hello, everyone. Welcome to our panel involving HIPS and DPA. My name is Jessica Guillermo Martinez. I work at HIPS as their methamphetamine services coordinator, and I will be your moderator for today. HIPS is an organization that exists in DC, and DPA works nationally. And I want to give Alex and Queen the opportunity to introduce themselves and talk about the organizations. So yeah, if everyone can just go ahead and introduce themselves. Alex can go first.
Hi, everyone. My name is Alex. I use he, they, or she pronouns, and I am the Outreach and Community Education Manager at HIPS. So work in our kind of direct services capacity here, overseeing a lot of our syringe service programs and also just our drug user health programs in general. And Queen, I'll pass the baton.
Alex. Thank you, everyone. I'm really excited to be here. I'm Queen Adasui. I use she, her pronouns, and I'm a Senior National Policy Manager with the Drug Policy Alliance. DPA is a national advocacy organization working to end the drug war and repair its harms. And I have worked on both the federal level and locally within DC to advance both marijuana justice, but also broader drug decriminalization and addressing collateral consequences for drug convictions. And Shane?
Damn, that was an intro. Love it. My name is Shane Sullivan. My pronouns are they, them, theirs, and I'm also here with HIPS, with the outreach department as a community outreach specialist, and have worked on the paraphernalia decrim and decrim campaign with these humans here. As well as been involved with HIPS since 2013 or so.
Awesome. Thanks so much. Queen, you actually answered one of my questions, but just to overview and give everyone an idea of what HIPS does, Alex, do you want to talk more about what kind of services we provide, maybe people we work with?
Yeah, absolutely. So HIPS has been around since the early 90s, and we are a full service like drug user and sex worker health program here in DC now. So we provide harm reduction services. We span a pretty wide range. All of our services have been kind of determined by the community based on the needs that we see folks expressing to us. So we started out really as just the outreach department, which is where Shane and I work now. We had a mobile van that drove around and handed out candy and condoms, and it was super low tech. And since then, that grew into one of the largest syringe service programs in the District of Columbia, which started in 2007. We also were instrumental in getting naloxone access in the district, and now we actually provide over 1,000 doses of naloxone per month to the community. We also still hand out candy and condoms in the van, and we have a drop-in center that provides things like clothing closet, food, peer support groups, and then clinical services, including medication-assisted treatment for people who are trying to curb their opioid use, as well as an infectious disease clinic that includes things like HIV and hepatitis C care, as well as gender affirming care for trans and non-binary folks. I think I got everything, but also actually, Shane, you've been collaborating a lot, as have I, with the advocacy department. Do you want to talk a little bit more about our advocacy work?
Sure. So I think like separately, DPA and HIPS have been involved in advocacy for a while in DC, but Tamika, but I guess we formally started partnering more at the start really of COVID, and we were involved in decrim of paraphernalia, which is like essentially in DC, like safer snorting and smoking equipment that until it was passed wasn't allowed to be distributed as part of our services. And I don't, somebody jump in, please.
No, you're good. Sorry, we were getting Tamika brought on
Well, since
screen.
we're talking about some advocacy stuff anyway, Queen, if there's anything you want to mention about DPA or like the work that you guys do, expand on that. I want to give you the opportunity to do that too while we get Tamika on.
Yeah, no problem. I mean, Shane was really speaking to it, and I just want to put out there, like, our work together is one of the most amazing things I've been able to really do locally. So I'm really grateful that we've been able to work together over the years. But last year, we successfully, after years of advocacy, decriminalized drug paraphernalia, which, like Shane mentioned, allows for the distribution and possession of safer snorting supplies for people, which I think is really important, and it's something that kind of like led into our broader decrim of drugs campaign, our Decrim Poverty DC campaign, which I'm really excited for us to talk about. You know, I mean, broadly, DPA works on ending the full drug war, which I think needs to be clear is not just about marijuana. So marijuana legalization is a part of that, but ending the drug war looks like making sure no one is incarcerated or arrested or harassed or stigmatized because they use drugs, and that we actually are intentional about addressing how the drug war has really devastated communities. I can just give like a quick overview of kind of like how we got to where we are now, like with the recent launch of our Decrim Poverty DC campaign, which happened a couple weeks ago. But at the top of this year, following, you know, the mayor signing paraphernalia decrim into law in December, we joined forces to launch and build really a coalition that we named Decrim Poverty DC. And we intentionally named it Decrim Poverty DC, despite the fact that at least our initial effort is focused really on addressing drugs and harm reduction in DC, because of how we know and acknowledge how the drug war has disproportionately impacted Black, Brown, and under-resourced communities in the district, especially people who are experiencing or living in poverty, and especially folks who are unhoused. And we really wanted to make clear that our effort is related to making sure that unhoused people, under-resourced people, people who are living in between margins, are actually uplifted when we are working to shift how we approach drug use and drug misuse. So we launched a campaign with a coalition of nearly 50 groups who are all calling for DC Council to decriminalize drug possession for personal use and establish a 24/7 harm reduction center, including expungement and resentencing and decarceration language, and a whole bunch of other like really amazing, really infrastructure that we're trying to build and fund, including funding the already amazing services that HIPS does, and other community-based organizations. So I've said a lot. I want to also pass it to other folks. But one thing I will leave folks with also is that we're working, and our campaign is broad intentionally in order to really stand in solidarity with other efforts to try to mitigate the harms of poverty that people are experiencing in the district. We stand in strong solidarity with the Defund MPD Coalition, the Sex Worker Advocates Coalition. Our campaign and our messaging and our effort is in complete solidarity with other efforts that are trying to reduce criminalization in the district, and we're all fighting for the same folks. So we're leading on the drug piece, but absolutely in solidarity with all other efforts that are happening. And yeah, Tamika's not on, but
yeah, I was gonna say, I've been messaging tech. Can we get Tamika added to the panelists? Tamika.
So my thank you so much, everyone. That was like awesome. I just want to disclose to everyone that I working at HIPS, HIV is a personal thing for me. I live with HIV. And you know, a lot of our work is trying to dispel stigma and trying to assist those with HIV, reducing transmission. So that leads into my next question, which is, how can working with people on their drug use help prevent HIV transmission? Anyone can take that.
I guess I should take that. I'll start, and Shane, please jump in. Everyone, please jump in. So yeah, I think a very long, Tamika, we, part of how like harm reduction services have traditionally even received any kind of like support or funding from the DC government or actually any state government is often tied to HIV and other kind of infectious disease prevention. Harm reduction services in general are very much about not just providing supplies, but also improving health overall. It's about improving the health and well-being of people who use drugs. And part of that, like from the get-go of our services, we, even when we started just as a sex worker focused organization, we had a peer program called Divas Against AIDS, right? And they would go around and do harm reduction education on how to do safer sex practices and safer injection practices for folks using hormones, because some of our clients are trans, and just like how to do HIV prevention. Since getting the syringe exchange program, DC has one of the highest rates of HIV in the country. And the syringe service program coming around in 2007, since that program started, we have seen transmission between injection drug users drop to the single digits in the district, which even the like medical director at our health department was like, this is 100% y'all. This is 100% harm reduction. This is 100% syringe service programs. This is 100% like Hips and Family Medical and all those other folks that are out in the field. And that's because it's more than just, handing out supplies. Like that's important, but it is about education. It is about like fully comprehending and understanding health and like building a community of support and health. So that's been really important to us. That is also expanded to hepatitis C as well, but HIV is kind of our roots. And to this day, we have everything from PrEP and PEP services to testing on site to actually like helping people get undetectable and get their medication if they are positive. So really we approach it from every angle, like hopefully prevention in a variety of different ways, figuring out whether or not you're positive. And then also if you're positive, non-judgmentally providing services to folks who are positive and wanting to get like their HIV under control. But I definitely want to, sorry, Shannon talks a lot.
No, that was perfect. Yeah, I think like just to add to what you said, like I guess traditionally people think of syringes and that's it, but a lot of folks that we interact with aren't interacting with any other provider or haven't for a while, and that's especially true since the pandemic. And there was just like the city essentially shut down, and I remember doing outreach and folks didn't know where to go for like any type of services. It was confusing, and it still kind of is like unclear like who's operating where. So linking folks is really important in that way. And I think like mobile services, low barrier services like HIPS are like often the only way that people are really going to engage with a system that treats them really shitty otherwise. So.
And if I can just add also, this is why it's important to end criminalization and why the paraphernalia work, which, we already had syringe access, but we didn't have other drug use tools decriminalized, but it's why criminalizing drug use tools, feeds into like unintentional spreading of infectious diseases, because people end up one, being stigmatized, two, often being put in a situation where they're either sharing supplies, don't have access to sterile supplies, and that contributes to, public health issues. So when we decriminalize drug use tools and then are able to actually offer people sterile supplies, we're able to see decreases in spread of Hep C and HIV. But also, people are also connected to other services that they may need. So, prohibition and criminalization in of itself is what's really worsening so much of the harms that we see related to drugs. It's not actually the drugs that in of themselves that often are the issues for people, but the environment that prohibition creates, that's what puts people in more riskier situations when it comes to drug use. So that's why harm reduction is so important, and why destigmatizing our work and destigmatizing our policies is critical to saving lives and also just improving people's lives.
That is so amazing, you know, and thank you, Alex, for mentioning how we literally ended a drug user HIV epidemic. Like, we did that, DPA helped us with that. Like, it's like, you know what I mean? Like, these programs work, and it's really important that we're talking about this. My next question, which Queen, if you want to actually start off with, I feel like you would have a lot of good things to say about this. Is there stigma surrounding HIV and drug use?
You asked if there is?
Yeah.
Oh, yes, absolutely. I mean, the whole drug war was founded on stigma. I mean, the foundation of it is driven by stigma and racism and xenophobia, and this idea that like people who use drugs are bad people. I mean, we have actual politicians who say that, like word for word, that they believe that people who use drugs are bad people, that drug use is a moral failure. And that's why we continue to say that, you know, a lot of the harms that we see with prohibition, including overdose, all of those things are policy failures. It's not about an individual's, you know, anything, behavior, anything. It's really about our policymakers, especially weaponizing policy against under-resourced people, low-income people, Black people, brown people, queer people, trans people, like people who are living within the margins or living at the center of different margins or marginalized identities are often disproportionately impacted by stigmatizing policies like drug war policies. The drug war and its policies are not founded in public health. There's nothing beneficial to public health about locking people up because they use drugs. And also there's no public health benefit to just assuming that everyone who uses drugs has an addiction. It one ties up resources when it comes to drug treatment and other services that like the minority of people who actually struggle with addiction and who want treatment could actually benefit from, versus the current status quo, which is, you know, anyone who's using drugs or in possession of drugs or even selling drugs, like obviously has an addiction, which is just not true. It's not founded in data. It's not founded in any of our lived experiences. And it's just, you know, it's time to actually end this failed policy, or in a lot of ways, I do think it's successful because the war on drugs was founded for political reasons. It wasn't about ending, you know, any kind of public health harms. So if we want to change course, we actually have to like reevaluate our approach, and our current approach is killing people. You know, rates of overdose over this last year, which, you know, the national data came out this week around, you know, almost 100,000 people, if not more than 100,000 people died in the last year alone because of overdose. And I think it's important for people to remember that overdose is accidental and preventable. And people are dying by accident because policymakers stigmatize them and stigmatize drug use. And I was just speaking on drug use, but people who live with HIV are absolutely stigmatized. I mean, people are criminalized for having HIV. So, you know, all of these things are really important. And that's why, you know, conversations about public health also have to tie into mass criminalization. Public health professionals can't keep skirting around the fact that criminalization has serious public health impacts. And it's not just about criminal justice reform and reforming the current system. It's really about evaluating how our current criminalization approach is worsening public health, community health, and individual health.
And what we're saying too is really not that radical. Like, it's kind of the bare minimum of what we need to do to address overdose and all of the issues around HIV and drug use. But the American Public Health Association endorsed decrim in 2014, and also overdose prevention sites. And so since that time, essentially, like, overdose deaths have nearly doubled each year. And there hasn't really been any fundamental change except for increased Narcan. And we've seen the drug supply just become entirely fentanyl in terms of opiates in DC at least, and like most major cities on the East Coast. And yeah, I don't have much else to add, but DC had 511 overdoses in 2020, which is like far surpassing any sort of number before. Like even just about 8 years ago when I started, it was like a mere fraction of that. Like it was closer to 100, which reflects just the failure of an actual like informed response that treats people who use drugs humanely.
I also just want to add to this point of HIV and drug use stigma. As someone who works in the stimulant side of, drug user health, there's a lot of association of methamphetamine use, unprotected sex leading to HIV transmission. So, stigmatizing drug users only leads to them internalizing the stigma that you are putting upon them. And then that stigma ends up actually leading to HIV infections, because who wants to use a condom if they're being called an addict? Who wants to, be safe if they're being called a tweaker? No one wants that. You know what I mean? So our language, the ways that we associate individuals can actually harm them mentally and can actually lead to individuals practicing unsafe practices due to the fact that they're internalizing what their community is telling them. So I think it's, really important that we remember that like there's this idea that, oh, if you do drugs, you most likely have like HIV, or like I've even heard AIDS, which who gets AIDS nowadays? You know what I mean? Like it's kind of hard, so thank you so much for that, guys. I think this, we kind of touched on this, but if anyone wants to expand on it a little bit, like how can decriminalizing drugs help reduce stigma surrounding HIV?
I can just start real quickly, and I may answer this even just a little bit more about drug users, because I think oftentimes policymakers and thinking about stigma are obsessed with this drug-free world that is never going to exist. And until they like get rid of this idea that we're going to ever live in a drug-free society, or if that's even like something that we should be aspiring to, because they've socialized drugs to be so bad, we're never going to be able to end all of the harms associated with prohibition until we're actually able to actually regulate drugs and allow for people to access drugs that are not adulterated, and people can know what they're using, and people have their own autonomy to use drugs for whatever reason they want to, whether it's for pleasure, for joy, and oftentimes people do self-medicate, which is a symptom of oftentimes a racist, transphobic healthcare system. Tamika's here. I'm gonna stop talking so Tamika can introduce herself. Hey, Tamika.
Tamika, hello.
Oh, you're on
You're
mute, Tamika.
muted. Please unmute yourself, mama.
You're still muted, love.
Tamika, you're still muted. It's okay. There you go.
Hi, everyone. My name is Tamika Spaldman. I'm the Policy and Community Engagement Manager for HIPS. All right, bring me up to speed on what the last question was.
The last question was, how can decriminalizing drugs help reduce stigma surrounding HIV?
Wow, that's a good question. And I got a big answer for that one. Number one, we shouldn't be criminalizing people's behaviors. Why are we segmenting people off into different fractions, putting everybody into these boxes when it's not everybody's reality? Everybody does not have chaotic drug use. I know at one point in my life I did, and I'm HIV positive too. I'm not ashamed of talking about that, because in all honesty, I didn't like sharing my instruments because I was, and then people, there are other things that you can catch. I would carry extra equipment for them, but I got punished for having that equipment. You know, and it's like anything I did to try to bring about some safety for myself was being criminalized because I had the wherewithal to make an adult decision for myself. You know, I remember back in the early days when HIPS was sneakily giving out those supplies, you know, and how it made things a lot easier for me not to have to share my works with other people. And then I think I need to say this. I had chaotic use around crack cocaine, but I am not using today, and I still drink and I smoke weed and I take pills as needed. And that is to illustrate that this idea of abstinence only, that you can never touch another substance, is foolishness. I had an issue with crack cocaine, that an issue is arrested. But it took me going through mental health services and not the court system to correct some of my own behaviors. You know, this is some of the things that are missing in these conversations, you know, about how we can correct people's behavior. Well, you don't correct the behavior, you can change a behavior. And that took some work to do. And none of the court systems, as many times as I've been arrested, ever made that change for me. If anything, it made my life a lot more difficult. It made it harder for me to stay under treatment for HIV, which is critical. You know, you can't play with taking those medications. And that medication interruption could have caused my body to go into this thing where it rejects that medicine and it won't work again. So them putting me in jail put my life at risk. It made my whole world upside down, having to go and take drug tests when I was not ready to stop using drugs. You know, that wasn't helpful. And then as this relates to HIV, this should be across the board with any communicable disease. I mean, what about hepatitis? What about tuberculosis? You know, these are things that you can catch by sharing an instrument you put in your mouth. We already tackled this with having a robust syringe exchange program. But then we have to be fully rounded out in how we're approaching drug policy to make this more effective across the board. It made absolute sense to go ahead and decriminalize all paraphernalia. Therefore, the move to decriminalizing the drugs themselves and having these conversations about having safer consumption sites. You know, when I think about safe consumption, it takes me back to alcohol prohibition and how we have these safe consumption sites today. They're called bars. We have safe distribution sites. They're called the liquor store.
Talk about it.
You know, it's real talk. When we stop the prohibition of alcohol, which is an adult beverage, is consumed by adults, we put sensible legislation in place around it. We ensure that the supply of alcohol is safe. I think that needs to apply to the rest of the substances across the board. It makes sense. And it's not costly. And then when they get into these conversations about treatment, this, that, to the third, well, those systems are already in existence. You know, I mean, it's not like we can't just make it more accessible. Would that be helpful? What do you guys think? You know, it makes sense, right? Instead of continuing to persecute me because I want to use. It didn't do anything for me. If anything, what it taught me to do was to become a little bit more sneaky and then start moving away from how I knew the police could criminalize my ass. I went into hiding with my drug habit until I got it arrested myself. It wasn't through court intervention because I circumvented it. I stopped dealing with it. I absconded from the law for 8 years. And in that course of those 8 years, I went through therapy, and that's what helped me. And then I came to the realization at some point that I needed my license back. That's why I had started to deal with the system again, because I was straight of my own accord and I wasn't abstinent. You know, these are hard conversations that, as a real person with lived experience, that people need to hear. Somebody that has lived with HIV since I was 21, and I will be 55 soon, by the grace of God. And it wasn't by the grace of the system.
I'm just like, Tamika, I'm so happy we finally got you on, because my next question was HIPS decriminalized paraphernalia in 2020. How does this address HIV transmission in DC? And you literally gave it. You literally came here and you gave it, mama. I just want to expand on Tamika's point a little bit more, just because a safer smoking and snorting is kind of like, I don't want to say a new concept, but is becoming a more mainstream concept in harm reduction. And harm reduction is simply a philosophy where you meet people where they're at and you help them get wherever they want to go without judgment, without coercion, and it's centered around the individual. So when we think about snorting and smoking, right? Obviously, with injecting, we can have blood present in a syringe and entering someone else's body. That's a clear point of transmission, because HIV cannot live in an oxygenated environment, right? Hepatitis can, but HIV cannot. Once HIV is exposed to oxygen, it just cannot survive. So how can snorting transmit HIV? To answer that question, for anyone in the audience who might be wondering, when you take a straw, you stick it up your nose, you're trying to get the drugs here into the blood membrane barrier, the one that actually reaches to your brain. It's in your nasal cavity. So when you hit that and you're constantly snorting, yeah, like the mucous membrane, the blood, like, whatever, the brain blood barrier that's attached to the mucous membrane. When you hit it with a straw, and you're constantly hitting it with a straw and adding abrasiveness, such as cocaine or methamphetamine, that can cause irritation and bleeding. If you bleed onto a straw and then someone quickly puts that straw in their nose, there's a slight risk. I want to be clear, slight risk, because HIV is not really transmitted this way, but there are cases where individuals have acquired HIV, and especially if an individual's viral load is higher, that increases the possibility. More importantly, though, snorting and sharing snorting equipment can easily spread hepatitis, as well as sharing smoking equipment. And sharing smoking equipment can also spread COVID. So, when we think about drug user health and we think about, oh, well, injection is the most likely to cause HIV, that may be true, but why don't we prevent every manner of preventing HIV transmission for drug users? So, Tamika brought up my next question, which was, we decriminalize paraphernalia. How does that prevent HIV transmission? Very simply, when people don't share equipment, their likelihood of getting HIV from another individual reduces to zero. So, we need to remember that, that when specifically for equipment sharing. My next question is, well, actually, we already talked about that. Our SSP killed the HIV epidemic. We know that. Needle exchanges work, y'all. How does HIPS and DPA advocate and support those who live with HIV? I know, Alex, you touched on this a bit before with some of our services, but if there's other ways that you want to talk about, or Queen, Shane, Tamika.
Oh, well,
I can think of a.
No. How do we advocate? We definitely bring lived experiences to the forefront. That is how we base our advocacy, is by letting those with their lived experiences come to the forefront and talk about them as it has affected them in whatever movement that we are particularly working on. As is with like sex work deep brown, there were sex workers that were pushed to the forefront to tell their own stories. We did storytellings with them. We had multiple events to talk about sex work, panels, discussions, roundtables, a variety of community events that we did. Same applies to drug policy. We let people with lived experience talk about their lived experience. You know, when I come into these rooms, I'm not talking just about what Tamika lived through. I have to represent for other people that don't want to come and speak for themselves. And I have to bring their experiences to the table too. Always thinking on my feet, how can I persuade whoever I am in front of how negative these policies are to sway them to think about an alternative approach? I know what worked for me, and I know how I can bring in harm reduction and help people to stop harming themselves and look at how that this could ultimately bring them to a point where their chaotic use is under control. You know, and there are a lot of collateral issues that have to play in order for a lot of these system changes to work. Number one is to defund the police. We need a funding source. We know they have money to pay them. So let's take half of the police force away and take that money and reallocate it for funding for services that we actually want, need, and desire. That would be to decriminalize the possession of drugs. Let us talk and move forward with these safe consumption sites. We need to have this conversation around ensuring a safer supply. You know, as I talked about the alcohol issue and prohibition, there were toxic alcohols, just like we have a toxic drug supply. If we could change that by putting some sensible regulations in and letting them put out a better product, we could address that. We could tackle overdose at the source. We can bring harm down. We can bring health costs down, because in its current form, this is where the issues and the costs start rising. When you're criminalized, people don't talk about it. They don't want to go see health officials until it's something critical, which costs more. If we address these things on the front end, we spend less money. And one of the other things that has to happen currently is to put in harm reduction teams that roam the streets like EMTs to replace the police for addressing issues with people that do use substances, those that have mental health problems, those that are homeless. We need to really look at what it means to address poverty in a village approach. You know, we're only as strong as the least of us. And if the least of us is weak, we're weak.
As a
Okay.
Queen, go ahead. Queen, go ahead.
I'm done.
I guess it's you, Alex.
I was just gonna say, as a harm reduction team that does roam the streets and take care of the yeah, and I think this like of everything Mama just said, and also like it's important, like part of the harm reduction teams roaming the streets and not acting like police and not acting like a surveillance structure is also going back to something you said earlier, really about recognizing each other's humanity and approaching people as people equal to ourselves, and also that part of us being from the community or being people with lived experience is how much easier it is for us to approach with non-judgment and from a place of experience. And seeing each other's humanity and approaching in that way sometimes looks like, first of all, not having this paternalistic like structure where we believe drug users are like incapable of managing their own health or uninterested in managing their own health, right? There are so many times when I've sat in meetings with people who are completely removed from community, who will just kind of make blatant statements, kind of assuming people who use drugs or people who do sex work or people in poverty for whatever number of reasons are responsible for their conditions and also incapable of making their own decisions, incapable of taking care of themselves, or don't even desire to do so. And as Tamika was talking about when describing her lived experience, like so many of like everyone I know and see every day one of their primary interests is taking care of not just themselves, but their community and making sure that everybody stays safe. The number of people that I know who for free go around and pick up used syringes and give them back to us and make sure that their neighbors are supplied, people who don't feel comfortable accessing our services, they do that for free. They teach people how to inject for free. They inject for them for free. Like, people do this and have done this forever. And so this idea and this kind of like assumption that, you know, we have to like, you know, tell folks how to do this or explain to folks how to take care of themselves or how to care about their health is ridiculous. People care about their health. The reason they don't access services is because of the stigma and because of the fear and because of the way that the medical community treats people who use drugs and makes assumptions about them. And also, by the way, a lot of the reason why people rely on an illicit drug market is that they're not getting the services that they need from the formal medical structure. They're not getting their amphetamines that they need to treat their ADHD. They're not getting their bipolar meds. They're not getting their pain medication because of this toxic gatekeeping medical structure. And I forget what the second thing I had to say was, but as a roving outreach team, harm reduction team, the other part of meeting people with humanity is recognizing that it's not all about a syringe exchange, right? Somebody who is hungry and hasn't eaten in 2 days is going to have a lot harder time having a conversation with me about their HIV meds or staying on their HIV meds, or hell, if they don't have a place to store their HIV meds safely, if their stuff gets bulldozed every couple of days by
not
the
even
city.
to mention that HIV medication sometimes requires meals to be taken and will work
Thank
effectively.
you. That
Have
part.
to be in a certain temperature range.
And has
And
to
being in a certain temperature range.
As does Narcan. You can't freeze Narcan, right? People living outside.
Yeah, you can't, like, if people are living outside in cold conditions, their Narcan, naloxone exposed to those extreme temperatures makes it completely ineffective.
Degrade. It makes it degrade. Exactly. So all of these things, like, we can't just go out and go like, hello, I am here to provide this. Goodbye. Like, it is a comprehensive approach. Does HIPS get any funding to get our meals? No. Do you know how much I beg every day to get literally people to donate cup and noodles and bags of chips? Like, I spend so much of my time fundraising for candy and food. It's ridiculous, but it's important because I can't have a conversation with somebody, and I don't want to have a conversation with somebody who's starving. I don't want to have a conversation with somebody who doesn't have their basic needs met, and then come in and be like, gee, have you considered your HIV meds? But that's how we're expected to function as non-human beings. And both the providers and the people receiving services, which, by the way, are often the same people, are expected to act in this vacuum. And it's not realistic at all. So if we're going to really talk about what like a roving harm reduction team looks like and what a roving social services team looks like, it needs to be comprehensive, and it needs to put the needs of the people we're serving first, and it needs to recognize that those needs are triaged and complex. I will stop there now.
Just to add to that too, I think like outreach is here because it's impossible to not do outreach and then see this like two-tier system and like practice every day and everything that Alex said. And it's like people living with HIV, it's people even accessing what's been approved as treatment who have to go to a separate clinic every single day for methadone. And just to add to Tamika's point about prohibition, this past year was actually the first year, like the rate of opioid use has actually dropped consistently every single year for the last, I don't know, like 4 or 5 years. And it's at the lowest point since 1988. This is prescribed opiates. And so the problem isn't with over prescribing. Right now, it's the lack of a safe supply. It's literally the opposite of what we are told constantly. And we keep doing the same things where we're introducing legislation to like target fentanyl, which has created fentanyl analogs, and it's going to continue like that. And it's bled into all of the other, like the rest of the drug supply beyond just heroin. So rant over, take it away.
Yeah, shout out to y'all because I feel like y'all like dropped the mic across the board. The only thing I would want to add is that like another way that we advocate for folks is one, also mobilizing other advocates. Like, I mean, I can't explain how many times I've worked with advocates who work in specific silos of different issues who don't see people who use drugs, sex workers, people living with HIV as their community. And oftentimes that limits the effectiveness of their advocacy. Like the amount of times I've had to work with housing advocates to empathize more with people who use drugs and recognize that like people who use drugs deserve housing too. And it's not just like sympathetic folks or people who, you know, there's more sympathy for them. And same for policymakers. Like we really like oftentimes bring our own lived experiences to the room, but also often have to connect the dots despite the amount of insensitivity we're often met with and lack of urgency, because everything we're talking about is like so urgent, and it's so frustrating doing this work oftentimes because it's like if we could just change the policies already, we could save lives. And we're often like having to do political dances and like having to be conscious of what a particular policymaker is interested in, which often is not about the actual community. It's about getting reelected or like whatever else is like relevant to politicians. And we often have to like get a really good understanding of politics, which is annoying because again, like this work has to go beyond politics. Like this is not about politics. It's like about saving lives. It's about health. It's about public health. It's about dignity, autonomy, things that should resonate regardless of political affiliations. But part of our advocacy is having to play chess with politicians. And then on the other side, like I mentioned with advocates, breaking down silos and like connecting dots even for other advocates and activists, which is why I continually call out marijuana activists who oftentimes can't see beyond their own experiences and don't recognize how even subconsciously how they, you know, stigmatize other drugs and other drug uses. And even, you know, when we think about psychedelics and like all of the opportunities there are when it comes to, you know, broaden access to psychedelics, all of the medical opportunities to address depression and PTSD and all of these really important things. But when it's not centered in the broader context of the drug war and criminalization and like prohibition, it's really disconnected from the actual reality of like who's really experiencing the like the extent of the harm of prohibition. So you know, that is also another way that we have to advocate, breaking down silos, playing politics, or at least using politics to our own advantage and being strategic to try to move our issue, because sometimes empathy is not enough. Politicians, a lot of times, especially locally, I think something in DC that's really difficult is that the people that we work for and work with are often not sympathetic to politicians. Politicians don't care about under-resourced Black people. They don't care about trans people. Like they often don't care about these communities. So like sometimes even like expressing, you know, the need for empathy and the need for dignity is not always enough. And that's why we have to like often be strategic and moving our issue, which is often very difficult and taxing because we understand the urgency of the work that we're doing and we understand the experiences that people are having that they don't have to have. It does not have to be like this. People don't have to die at the extent that they are dying. And people also, even beyond death, like the actual quality of life that people are maintaining, it does not have to be like that. Mm-hmm. So that's another thing that we have to grapple with.
Thank you so much. Like, honestly, isn't our panel awesome? I'm loving this today. We have 3 questions left that I prepared for us, and we've got about 15 minutes before I wanted to go into a QA. I wanted to give 15 minutes to the audience for a question and answer period. So I'm going to ask this question. I must use the restroom, but my question is, how important is U equals U to a syringe service provider? So to explain what U equals U is, U equals U stands for undetectable means untransmittable, meaning that those living with HIV who have a viral load of under 20 copies are incapable of transmitting the virus. So how does that help a syringe service provider?
I mean, I guess I can try to take this. But like Tamika or Shane, please feel free to jump in. I mean, I think it just goes back to the importance of like having those wraparound services as much as possible. The syringe service program in and of itself is more of a prevention measure, right? We're trying to prevent the transmission of HIV, but another form of prevention is folks who are HIV positive being undetectable, right? And there's a lot of different ways that folks can stay safe. And I think this speaks to the harm reduction model of like, some stuff is safer than other stuff is one of our like guiding principles, but also some stuff is safer than other stuff is relative. You can have a person who's HIV positive and engaging in a sexual encounter or even like sharing drug related supplies with folks, which we don't, obviously we want that not to happen. And with a syringe service program in place, hopefully that doesn't ever happen. But like, for example, let's say, you know, a person is positive and maybe like in that context that Jessica was talking about earlier, right? Like, you know, sex and drugs may be mixed together, and there may be situations where people aren't using barriers or where people are, you know, making kind of decisions that, you know, in the heat of the moment are different from what they would make in other contexts. Being undetectable in that context is another stopgap between HIV transmission. So we want to approach, like as harm reductionists, we want to approach health from a bunch of different angles. We don't just have one solution to any given problem. Condoms are not the only answer to safer sex, right? There's also being properly lubricated, and there's also avoiding micro tears, and there's also, you know, making informed decisions and having conversations earlier and consent and things like that. And, you know, drugs can add complications to that mix, but having folks who have their care managed and have their treatment managed can put up like a stopgap between some of those behaviors that might be like in the heat of the moment happening and still not having transmission of HIV between folks. And I think it also speaks to the importance of a harm reduction organization, if at all possible, offering those services on site, because a lot of folks are facing a lot of judgment and stigma and barriers when going to more traditional medical settings, and oftentimes are denied services. And we saw this, I know this is an HIV related question, but we saw this in particular with hepatitis C, which is a curable disease. But in the beginning of hepatitis C, when we were like really first seeing the treatment drugs come to the market, drug users were actually excluded under the rules of medical providers. So people who injected drugs were not allowed to receive hepatitis C treatment under the medical like regulations. They were they were like disqualified. And HIPS was actively part of the research study in collaboration with the NIH that proved that that was nonsense. And the NIH came and did a study at HIPS with active drug users to see whether or not active drug users could still be treatment adherent and get their hepatitis C treated. And lo and behold, drug users actually care about their health and got their hepatitis C treated. Amazing. But like it just speaks to, like, again, that paternalistic nature that like drug users can't possibly make.
Didn't we, with our study at HIPS, prove that we had a higher adherence rate and clearance rate as well?
Yes. Not only, yeah, we had a higher adherence rate than anybody.
Amazing for drug users. People, what do you think about that?
Yeah, so like HIPS actually started the study that proved to doctors that drug users, when engaged about their healthcare choices, will actually begin to care about their health, go to trusted physicians, go to trusted healthcare individuals to try to mitigate some of the damage that has been caused by maybe some of their choices. And that's not to put stigma on their choices. That's simply to say that, you know, people struggle every day. Like Alex was saying, with mental illness, with unmedicated issues. And, you know, like what HIPS showed is that if you actually engage this population and you know, care about them, you're actually capable of healing them. So that is something really spectacular. And I just want to point out one last thing about U equals U. If an individual has an undetectable viral load, if they share syringe equipment with someone else, they will still not pass HIV. And sharing equipment is actually one of the main ways that people spread HIV. So, I think like this conversation is really great. My next question is, how has HIPS DPA educated people on U equals U? And give me one second.
What happened?
Not sure. How has DC been handling U equals U? In a variety of ways, most of them I had talked about, but it's kind of a combination of prevention, and prevention is also kind of like multi-tiered, right? So that might look like syringe exchange, it might look like safer sex supplies, barriers, it might look like PrEP or PEP, which are pretty freely accessible in DC. And then on the kind of like response side, which is the U equals U side, it looks like keeping people connected to treatment. And HIPS does a really good job of that, because we will literally, that's why we have an outreach team, we will literally go find you and be like, hey, you missed your appointment. Do you need your meds? And they're like, oh yeah. We're like, cool, come on.
But we have that kind of a rapport with the client base that we have, that we can approach them like that and they don't take offense to it. It's not every organization that can get away with that type of rapport with their client base, because we treat them like they're our family. We go out there and shoot the shit with these folks. We talk to them just like I talk to my mama, my brothers, my siblings, my family. It's because they're humans. Drug users are people too. And it's very disheartening to hear journalists calling us junkies. I'm a human being. How would you feel if we started putting labels on you?
Hi, I just want to address a question quickly in the chat. The reason I am also speaking is because I am part of the panel and I actually work at HIPS. I mentioned that in the beginning of the presentation, if you were aware. But if you're not, I actually work at HIPS and these are all my coworkers. So I apologize if you think it's rude that I'm adding on to my coworkers' opinions and comments, but I just work with them and I'm just trying to expand the conversation and make sure we hit everything. So I apologize if that inconveniences you. My next question is, how can we better support those living with HIV?
I also quickly just wanted to clarify that.
Sure. Oh, about DPA, yeah.
Yeah, DPA doesn't do direct service. We're largely an advocacy group and we support organizations that do direct service. So I guess that would be the way that we support and even engage in U equals U. But we don't do any direct work around U equals U, just because of our scope and because we're an advocacy organization primarily.
The other piece about the related to paraphernalia is that it's another option for people besides injection, and there's risks with every type of route that you're using drugs, but in general, it's generally a safer route, or at least it's an option for people if we have those kits legalized and ready to give to folks, including people who maybe didn't see themselves as drug users, or people who could access a harm reduction org because they're not injecting, but they're smoking or snorting.
Awesome. Yeah. And I just want to give people the opportunity to continue the two questions. How has HIPS DPA? Obviously, Queen said DPA doesn't do direct service advocacy, but advocating for those and those using drugs obviously helps those living with HIV because it helps prevent transmission. So yeah, really my last two questions were just, how can we educate more people on U equals U, and how can we support those living with HIV? Like me and Tamika. So I just want to let the panelists take it, and then you guys got about 10 minutes.
So where I see support is like with HIPS, we try to provide as many wraparound services as possible. We are a full service organization. We kind of try to advocate on every aspect around sustainability for people living with HIV, and that starts with housing. Housing is a must if you want to be stable and when you have HIV or you're trying to prevent it, because you need to take those medications. And if you're homeless, it is hard to stay on pills. They become rendered ineffective if they're into wild, extreme temperature changes. So that still leaves you vulnerable. We also provide treatment adherence. We have group therapy for people to come in and talk about, taking their medications, because some of those pills can hurt. If you don't eat properly, sometimes when you take those medicines, it gives you extreme pain in your stomach. And then a lot of those medicines can be toxic to the body. So we have to sit back and talk about how we all mitigate these harms that come from the medications that we have to take. And then we also have a food pantry that we try to make sure that the people that are positive have proper nutrition. DC is expensive. Food costs a lot in the District of Columbia. Fresh foods and vegetables for people that are in those impacted populations are expensive for them to maintain a healthy diet. So we try to make sure that we can get them some healthy foods in on a regular basis. I've been pushing very hard to expand our pantry services because of the overwhelming jump in need. It was like a 300% jump in need for food during pandemic. So that has prompted me to ask every one of my funders to help us to expand our pantry so that we can do more food distribution amongst the populations that we serve. And then it's also with me advocating for change for them. DC is pushing out public housing out of the market. There's a lack of affordable housing in the district. So I'm being thoughtful and working with coalitions that are working on some of these collateral issues to help us to address sustainability for people with HIV. And that number one thing is going to be housing stability.
To that point, I think that's why it's important that decrim poverty is such a broad base of folks. Like Queen mentioned, there's almost 50 other orgs involved, and they're all from different backgrounds that are all important and see the common thread here. And I think I lost my other point, so you could jump in.
I mean, I'm happy to jump in on that because really, I think what's clear, and maybe not clear to everyone, but it's clear to us, and it's something that we're pushing out and trying to make clear, that is that the drug war has infiltrated all of the systems, even just beyond a person's experience being arrested and incarcerated for drugs. The drug war and drug war policies are in every system, in our healthcare system, in the child welfare system, in housing, employment. When we say we want to end the drug war, it's comprehensive because the harm of the drug war has been so comprehensive. And people who are living in vulnerable situations are feeling it the most. People who are in elite situations, people who are wealthy, people who have access to resources, may not feel the extent of the harm in the same way as a person who may already be economically or socially struggling. So that's why a lot of this, again, is not an individual problem. It's really a systemic problem. And we're trying to change systems in our work. We're trying to transform systems to actually care about people and actually meet people where they are. And frankly, we've wasted so much money with the drug war. It's about time, well, not only just the drug war, but really even in mass criminalization, like the ways that money is used to punish people has only, again, resulted in harming people in ways that are not repairable even. So even in our work trying to repair the harms of the drug war, there are limitations that we have. I mean, how do you repair the harm of someone losing their child? How do you repair the harm of someone being permanently deported? How do you repair those harms? So, to really speak to the question of like, how do we support, folks living with HIV, the goal is to support all folks who are living with marginalized identities, who are living with chronic conditions. The work is expensive, the drug war is expensive, so that's why our advocacy looks as broad and comprehensive as it does.
Yes, Queen, everything you just said. And it just brings me back to like the question of why is criminalization an HIV issue? And it's like, first of all, I see so many parallels between, and this is not, my like total area of expertise, but I see so many parallels between criminalization of HIV status, right? Of transmission, of how we treat people with HIV as just like walking disease vectors, right? Which is horrifying. And it's that same kind of bias and stigma and dehumanization that we do to people who use drugs. We just see them as walking criminals, right? Like if you go on any next door message board, like the amount of times you see the word criminal thrown around as if that's a person's entire identity. I mean, criminality is largely like a manufactured concept, right? I mean, there are things that cause harm. Murdering people causes harm, for sure. Like that's a problem. But inherently just having or using drugs, like people in power, not even we, screw that. People in power decided, first of all, that drugs were going to be criminalized, which drugs were going to be criminalized, and who was going to be criminalized for them. This is a made up concept, and it's also made up enforcement. The enforcement is completely biased as well. And so and that's true for both HIV criminalization and for drug criminalization, and paraphernalia criminalization and sex work criminalization. Like all these things are tied together. But like it is a deliberate and intentional process of dehumanizing people who use drugs, of especially decriminalizing Black and brown people who use drugs, of especially criminalizing people who are poor and living at any number of other margins. And so like criminalization of behaviors, of identities, of health status, of mental health condition, of physical health condition, like we should be terrified of these things. And the only reason that we don't seem to be is a lot of people see people living in those identities as different and like lesser than themselves. And that's a real problem that we need to sit with societally, because people cannot safely access the services, supports, and healthcare that they need to prevent and or manage their HIV if they know that they can't safely disclose that they have HIV, if they know that they can't safely disclose that they're a sex worker, if they know that they can't safely disclose that they use drugs. All of these things are intentional barriers, and it just sets everybody up for failure and everybody up for harm. And it's a gate. It really is. I don't like to talk about gateways, but it's a gateway, and we see it. It's why we have the movement called Decriminalizing Poverty, because our end goal is to get rid of all criminal offenses for nonviolent things that don't cause harm to anybody. And that really is like the comprehensive package that we're aiming towards. And we're starting with drugs because that's the one that's caused like the most harm, I think we can kind of safely say, in terms of like sheer numbers. But this is a broader issue that we have to look at holistically, which is harm reduction's way of life anyway. So
I think there's a parallel there between the HIV/AIDS crisis and overdose happening right now, and queer people being impacted, and also like young queer people not necessarily knowing that history. And I think like that's been really lost and not talked about enough. And there's just like clear parallels between how we're treating this right now in terms of people dying, preventable deaths, and the population that we're talking about, and the general attitude towards people who use drugs, in the same way that that exists still for people living with HIV.
And on Shane's point, I think there's a whole history and present experience of queer leadership, even in drug policy specifically, especially queer folks who are living with HIV. Like, there are countless like drug policy reform victories that were led or championed by queer people, especially during the HIV and AIDS crisis, at the height of it, where people were literally, you know, providing things that were necessary for their community members despite criminalization. When I'm thinking about, you know, the ways that people made edibles accessible for people who were living with HIV, at a time where, you know, their humanity was just completely dismissed because of their condition. And I think that's something that a lot of queer folks are like disconnected from, that history, and again, current present, because there are plenty of queer people in the drug policy reform space who are, you know, champions of drug policy reform. But then also I wanted to piggyback off of Alex about our campaign, and our effort is really centering the fact that people who use drugs, sex workers, again, all the folks that we've been talking about, they're our neighbors too, and fighting back against NIMBY attitudes, and making it clear that all of these folks are also community members who have a right to be there, and have a right to dignity, and have a right to accessing resources that actually will help them live stable lives. So, you know, our campaign is meant to highlight that, you know, it's important for our policies to recognize the humanity of people, regardless of what people with more access to power may feel about it. NIMBYism is, you know, really such a huge barrier to things that actually will save lives and actually will improve everyone's community health. Like, I think sometimes, often, especially with people who tend to have more access to resources and power, they can only see things through their own individual lens, and they don't see how collectively everyone's health benefits our own individual health. So until we stop allowing for NIMBYism to get in the way of effective policies that actually save lives, we're not going to be able to really maximize public health. So yeah, that's what I wanted to add.
Why don't we give it up for our amazing panel, everybody? You guys killed it. I just, you know, before I sign off and let the audience ask questions to my fellow coworkers and Queen from DPA, I just wanted to say it again. I am Jessica Lisa Martinez, a woman living with HIV who's happy to be working at HIPS as the methamphetamine services coordinator. I am very, very humbled that I had the opportunity to host my coworkers and Queen here to talk about HIV, stigma, and drug use. So I want to just open up the chat to any questions in these last 5 minutes we have. And this is me signing off. Thank you, everyone.
Will the questions come in the chat? And thank you, everyone in the chat as well.
Yeah, thank you. That was really
Yeah,
sweet.
thank you so much. We've been getting some good questions. I've been trying to field some of them through text. But if I missed anybody, please do drop the questions. How can we address poverty and marginalized people? I see as a question. Does anybody want to take that? I mean, maybe Tamika or Queen, do you want to start?
I guess number one, we could start with making housing a priority. You know, housing is a human right. You know, the right to a job is something that we really need to discuss as well. You know, just like we need to talk about what a living wage job is, because $15 an hour is a joke in the District of Columbia. I can't live off of that. I mean, come on now. You know, if we want to talk about what wages should be, we should be looking at something like $27.50 an hour. That's what they should be. You know, we need to be looking at how we bar people from getting employment. You know, why am I having to pass a criminal background check to do a damn job? My ability to do the job is the only thing people should be concerned about. I shouldn't have to pass a credit check. I shouldn't have to do a drug screening. You know, I swear, if you really want the honest truth, I do my best work when I've smoked a lot of weed before I come to work. You know, you might want me to let me smoke a little weed to keep me a little bit calmer, and I haven't murdered anyone yet. You know, I mean, I use it as you know, for my depression, for real. You know, it works way better than it works way better than those man-made pills. They made me worse trying to come off of them because of the weight gain that I can't get rid of now because I took them for so long. I can't get rid of this weight now. You know, I took a crash that almost took me out of there because when I came off of those pills, they didn't tell me I had to wean myself off. Yeah. But if I stop smoking weed, I bet you I'm gonna be okay.
I hear you, Tamika. I just want to piggyback. Housing and meeting basic needs collectively, I think also access to universal health care and also like sensitivity and competency of that healthcare. We need to basically revamp the entire medical system, in my opinion. I'm seeing some questions about like work and small business and entrepreneurship in the chat. I think all those things are great and that they are needed. I also just want to hold space for recognizing that people deserve humanity and safety, whether or not they are working. There's a lot of people who have disabilities. There's a lot of people who, for any number, who are providing care for children or elders and like don't have the capacity to work a full-time job for whatever number of reasons. And we need to value people's lives regardless of whether or not they're working. Work is great. And I think we also can get more creative about what work looks like. Like people who are sex workers are working, right? They may not be working in a formal economy, but they're working. And so like, that's an entrepreneur. A sex worker is an entrepreneur and they're real good at it. So I think we just, marketing, yes, and we need to get more creative and not base people's like deservingness of dignity on work. That's just my 2 cents.
I definitely agree. Like completely what Alex just said, and even like expanding on stopping punishing people for operating in informal economies, including selling drugs. Like maybe if our economies were less racist and transphobic and all of the things that it is, like people would be able to actually, you know, provide for themselves in a way that society thinks is appropriate. But either way, folks in informal economies are providing services and they're working and they deserve dignity. And I think it's really important to really land the point that regardless of a person's ability to work, housing is a right. Being able to access healthcare that sees them as a human being is a right. And that is not something that someone, you know, earns or is a privilege. It's absolutely a right, and we have to fight for that. So thank you, Alex, for bringing that up.
Thank you, Queen.
A little historical context. When you go back in American history and you look at when we started seeing this flourishment in the way laws were brought about and created, you go back to the time when emancipation happened. You know, there were lots of slave plantations where sex work was done, and it was a celebrated and acceptable thing. But then it became a moral issue when Black people were being paid for the work themselves. You know, and it became a fight of controlling Black people. We need to really look at that, because when you look at the history of the District of Columbia, there were brothels all over that city. Brothels just west of the White House in the neighborhood known as Logan Circle. And it's still a lot of sex work being done in that neighborhood. And people, the gentrifiers, are so upset about it because they didn't know that they're moving into that area. It's a historic area. And just because your home is no longer being used as a brothel did not mean that they didn't exist. Those are things that are the informal economies have all been criminalized. You know, and it was once people of color became available to do work for themselves and not work for other people and not profit from it, it became a problem.
Yup.
And that's just the real talk of it.
Shane, there's a question that says, what have been the biggest barriers to starting your safe use sites? And I have some thoughts, but I know you do too.
Everybody loves to cite that DC is like unique in being federal. I don't really see how that's a barrier, but I feel like there's a lot of stalling and unwillingness to be like brave or, you know, I feel like there's not traction happening because people support it like in theory and talk about the urgency in theory, and there's a lot of like theatrics around that with like government officials who call like say that public health is the answer and then don't support decrim, don't support OPSs. I think also just like people need to just hear about it more. It's not as like organic a concept as decrim for some folks. Like, and I think that's just something that needs to be centered when we talk about overdose and like the toxic supply.
Agreed. I just to add on, hopefully I don't lose my job, but we exist in a couple of like intersections of resistance. I think it's hard not to name the fact that our executive leadership in DC is kind of like openly hostile to people who use drugs and people who are poor, and like provides a lot of lip service to caring about public health, but not a lot of actual like support or tangible like policy reform, and in fact has like written Black Lives Matter on a plaza and then like openly stated that they were going to refuse to even consider cutting the funding of police or reallocating some of those services to health or social services supports. So, you know, if there is a lot of talking out of both sides of the mouth, and also honestly, we get touted as a very liberal city, but there's a lot of like really conservative streaks. And I don't mean like politically, I mean like in terms of being afraid to take action and make radical change that would be necessary to literally change the way we think about other people and how we interact with each other. It takes a shift in our imagination and in the way we engage with each other to go from believing that, you know, people who buy, sell, and use drugs are criminals who need to be like contained and locked up and are causing violence, to like human beings with complex lives. And that's just not like, people aren't ready for that, especially in a lot of like leadership positions in DC right now. People who have decision-making powers, people who are at the heads of like some of the major players. I won't name names because I will get fired. But like, I think
Let me
that's,
do it.
no, please don't, I need you. But like, I think so, but to answer that question in a more like broad way for other people in other places, like find your champions in government, find your champions in your legislative branch, find your champions at your like departments of health, at your departments of behavioral health, whatever exists in your place, and find your community stakeholders who have the ear of those people who can change hearts and minds. Because if we don't start with like a broad coalition of folks who are trusted in the community and trusted by leadership, and those may or may not be the same people, then you're not going to get policy change to effect. So that is my 2 cents. Oops, we need to wrap up. Sorry, my bad. Tamika or Queen, I'm sorry.
Oh, I mean, y'all killed it. So we only have a couple minutes left, right? I don't know.
The campaign website is decrimpovertydc.org. I don't think we mentioned it before.
Oh, wait, no, sorry, I put the wrong one, my bad. yeah, please check out our campaign website. If you're a native or if you're a Washingtonian or if you live in DC, if you're a DC resident, please fill out our petition. Follow our campaign Twitter, Decrim Poverty DC, for updates. And yeah, thank you for attending and listening to us. And I hope this was helpful.
Thank you so much, everybody. We really appreciate you.
Thank
Oh,
you.
we have an announcement.
Okay.
No, go ahead, Tamika. I guess they're not coming.
No, I was just saying thank you all for attending. We appreciate your time.
All right, I guess we're gonna jump off. Goodbye, everybody. Thank you
Yes,
so much.
Thank you all.